Morning, good afternoon, and good evening to all our urology trainees spread all over the world based upon the place from which you are hearing this video. Thank you for joining our YouTube channel to discuss the various urology exam preparation scenarios. We are doing 65th episode in our series, and in this mock exam series, we are discussing emergencies in urology. We have a trainee with us. Thank you for joining us.
Thank you. Thank you so much, Mr. Dhanashekar.
Okay, your time starts now. You have a patient, 72-year-old, presented with acute urinary retention in A&E. A&E team on examination found his bladder is distended up to the umbilicus, is a little bit frail, and they managed to catheterize. 1.2 liters of clear urine with some mild blood staining drain. And how are you going to evaluate him?
So I'll review this patient promptly myself in the A&E, where I'll first see if the patient is stable. From the history, it does sound like he's stable, and then I'll proceed to take further information, including the history of the events that led to this presentation. If he had these voiding and storage LUTs for a long time, if he's had any prior episodes of retention and catheter placement, if he's on any particular treatment for this. Any other red flag symptoms such as hematuria, pain abdomen, fever, vomiting, history of constipation and neurological illness, past medical history, drug intake, allergies, history of constipation, any prior urological interventions, any prior cancers and pelvic radiotherapy. I'll then proceed to examine him. I'll check his observations again. I'll before this, I'll make sure that he's comfortable and he's had some pain relief, and this I'll do with his consent and in the presence of a chaperone. I'll check his abdomen for any suprapubic dullness or tenderness, flank tenderness. Then I'll check the catheter which has been placed and if it's draining and how much blood is there in the catheter. They said it's blood stain, but I'll confirm myself the degree of hematuria. And then I'll proceed to do a digital rectal examination where I'll look at the prostate, the size, and if there is any nodularity which is present. I'll organize for his blood test, including full blood count, UNEs, and coagulation. I'll also ask his urine output to be monitored on an hourly basis. And depending on the results, I'll decide his further management.
Okay. His urine output is, as I said, 1.2 liters in the first instance, and then he is pouring out good amount of urine. His DRE showed 50 cc smooth filling prostate, no signs of any suspiciousness. There are no signs of any sepsis. His blood showed his EGFR has fallen from 80 to 23, and his creatinine is quite high. His electrolytes showed sodium is 135 and potassium is 6.6. Other results are a little bit marginally abnormal but not significant. Hemoglobin is normal. He is conscious and alert.
So because of these results, I'm worried that he has high pressure chronic retention and he has hyperkalemia. I'll get his ECG, and if there are any changes on the ECG, I'll start him on calcium gluconate, and I'll also start other potassium measures. I'll inform the ITU and HDU team that we may require a bed in the ITU. I'll admit this patient initially under urology and ask the nurses to continue monitoring his observations every 2 hours by using the new score. I'll continue to monitor his urine output and make sure that he's getting fluid replacement with 50% normal saline compared to his last hour's urine output. That's all which will be my initial management. And then I'll continue to monitor him. And depending on how his potassium level responds, I'll decide his further management.
Why are you doing ECG?
Because he has hyperkalemia, there's a chance that he may have peak T waves, and this hyperkalemia can be cardiotoxic, and that is the life-threatening implication of hyperkalemia, and that is something I want to pick first.
Okay, so if there are some peak T waves, you said you are going to give calcium. What calcium? What is the dose?
So calcium gluconate is given as 10 milligrams in 1 ampule of 10 milliliters over 10 minutes. This is a single dose of calcium that is given, and then we can monitor his ECG. Then we can put him on continuous ECG monitoring and see how he responds.
Why calcium? How it works?
So calcium stabilizes the cell membrane of the cell membrane, and it stabilizes the cardiac cell membrane, and that is how it prevents cardiotoxicity of potassium.
Okay, so how are you going to treat his hyperkalemia? You're treating the cardiac side effects.
So hyperkalemia can be managed by giving him insulin and dextrose. I'll give him I'm sorry, I don't remember the exact dose now, but I'll give him insulin and dextrose. I'll give him nebulization with salbutamol, and I'll give him calcium gluconate as discussed before. I can also give him potassium binding tablets. These are the basic management of hyperkalemia.
What are the potassium binding tablets?
I can't remember the name now, sorry.
Okay. Why insulin? How it works?
So insulin works by pushing the potassium into the cells. So it causes intracellular movement of potassium, and thus reducing the level of potassium in the blood.
So why are you giving dextrose along with insulin?
Because I don't want him to have hypoglycemia.
Okay. Why salbutamol?
Again, salbutamol works by the same mechanism that pushes the potassium inside the cell membrane, intracellularly.
Okay. And you're doing this, but when are you going to repeat his bloods, and what is your next steps?
So I'll repeat his bloods again in around 6 hours from now. And depending upon the potassium level, then I may have to repeat another course of the same treatment for him. And this is how I'll monitor him. I'll also make sure that he's getting the fluids that he requires, and I'll continue to monitor him clinically as well. Since he has high pressure chronic tension, he's not a candidate for TFOC, and he's going to be under a long-term catheter for now. I will assess his ASN performance status and see if he's fit for bladder outlet procedure, and then I'll decide which procedure I want to do for him.
Okay, in case if his potassium is not decreasing, it was 6.6 to start, and then in 6 hours time it is still 6.4. How can you manage him?
So if his potassium is not decreasing, I'll involve my nephrology colleagues. And since this is hyperkalemia, which is refractory to medical management, this is an indication for hemodialysis. But I will ask them to assess this and see if the patient can benefit from hemodialysis.
So what is the principle of hemodialysis? What are you trying to achieve?
So hemodialysis works by the principle of dialysis, of osmosis and ultrafiltration. It works by... so osmosis is when the molecules from the body move passively along a concentration gradient. So the dialysate solution will have lower amount of potassium. So the high potassium from the blood will enter the dialysate solution. In this way, we can reduce this potassium level. Ultrafiltration works by reducing the amount of fluid in the body. Since this patient is not in fluid overload, that is not much of a concern here. However, before doing dialysis, we'll have to place a significant central venous access, which can be either via the femoral veins or the subclavian or the internal jugular veins. So this is a significant undertaking, and I will involve my nephrology colleagues for this.
Okay, his urine output hourly in the table stated as 900 ml, 915 ml, 850 ml, 760 ml in the first 4 hours. So what is happening? Why is producing so much of urine?
This patient is in post-obstructive diuresis, and this is why he's producing so much urine. The mechanism here is that there is a loss of medullary concentration gradient because of failure of reabsorption of sodium from the proximal tubules and urea from the distal tubules. This leads to inability to create and maintain a normal concentration gradient. It's also because of the reduced aquaporin receptors in the distal tubules, which leads to reduced reabsorption of water and reduced sensitivity of these tubules to vasopressin. Further, because of fluid overload, because of urine retention, there is increased atrial natriuretic peptide, which causes diuresis and natriuresis.
Okay. Is there any types available in post-obstructive diuresis? Any classification you are aware of?
No, I'm not aware of any classification of post-obstructive diuresis.
Do you know what is pathological post-obstructive diuresis?
Yes.
We'll stop there.
Sorry. Yeah.
So as you saw, I purposefully concentrated on the post-operative diuresis and hyperkalemia part of high pressure chronic retention. So that is emergencies.
Yes.
Okay. So they won't really take you into your follow-up 3 months later outlet surgery. Those things are like normal male LUTS stable.
Yes.
You did well. I'm quite happy the way by which you have brought in so much of theory knowledge in that. My few advices are, in the initial stage, there is a small possibility the patient may go down the path of sepsis also. Okay. So whenever, I mean, you can say 9 out of 10, it is a very clear-cut high pressure chronic retention. Anybody can say that. But just slightly concentrate on the sepsis part. Make sure that you are considering an eye on the observations to make sure there is no sepsis, like increased CRP, WCC count, and those things. Don't just concentrate and what can I say, have a tunnel vision on only one diagnosis. But with the second question itself, you will know what the examiner wants and where the examiner is going to take. So this is the trick for all the tables. First question, you should really come down to 2 or 3 scenarios with which the patient is going to travel. In the second question, you will know where the examiner wants to take you, so you will concentrate on that. So don't condense yourself to one diagnosis in the first scenario itself. Slightly overplay, keep yourself a broad feet. Say that you will make sure that there is no signs of sepsis. No need to discuss in detail, but that will help you so that you won't miss. Sometime unnecessarily we may get down into a wrong path. ITU is a good answer. A lot of units nowadays use high dependency unit rather than intensive trauma unit or intensive treatment unit, because ITU means it's too much of sick patient. HDU means it's more of like a bridging. And there are few other ECG changes also, like increased Q, RS, widening. So try to get all the details so that it's more theoretical knowledge. As I said, knowledge, communication, application of knowledge. Your communication is fine, application of knowledge is fine, but the knowledge can be further drilled into much more elaborate. If there is a 3 findings in ECG, you should be able to bring all the 3 findings. Encourage oral fluids, because it's not very safe replacing only with IV fluids. You're not going to take him to theatre for any reason. So encouraging oral fluids, and blood pressure in sitting and standing position. That is one of the
and weight.
And weight, daily weight. Maybe in the first 2 days you may have to do even 12-hourly weight. Sitting and standing BP is very important to know the fluid deposit, and also that will only guide you about that patient's fluid overload or not. If there is a good decrease in the blood pressure when the patient is standing, that means there is a third space loss which you can fill it confidently. Little bit more confidence in how insulin works, you did well. Dextrose is fine. Little bit more confidence in salbutamol and potassium tablets and those things. You can be a little bit more confident. It's more of dry theory knowledge. And pathological high pressure chronic retention is the one where the diuresis happens irrespective of whatever you do. While physiological means patient had a retention. Because of retention, he didn't pass urine for maybe like 24 hours or something around that. Because of that, physiologically, he has accumulated intravascular and extravascular fluid, and physiologically, he's excreting that. This is fine. So it's a physiological one. Once the outlet is cleared by a catheter, physiologically, all the accumulated fluids are coming out. This is normal. This is supposed to happen. If this happens, the diuresis will slowly reduce. You won't see in the region of 900, 800 ml for 6 hours or 8 hours. Within 2 hours, you can see the hourly output comes to 250. Within 6 hours, it will come to say 100. Within 24 hours, patient will improve. So that is physiological diuresis. Pathological diuresis is the one, as you said the mechanism correctly, the medullary concentrating ability is gone. Patient don't have enough intravascular and third space fluid. Patient may be even low in the fluid, but still diuresing a lot. That is pathological diuresis, which is much more serious, and we need to keep a very close eye. You can't replace too much of IV fluid also, but at the same time you need some renal replacement therapy, like how we discussed about hemodialysis. Okay.
Right.
Good. Any questions before we go to next scenario?
No, I think that was all.
Good. Okay.
Thanks.
Can we go for the next? Welcome. Can we go first next scenario? Ready?
Yes, please.
Good. Your time starts now. You did a TURP monopolar using glycine for a 70-year-old gentleman. The procedure went well. It's a large gland measuring around say 100 cc, but you felt you have resected clearly all the 3 lobes, good hemostasis, patient is in recovery. You have sent for your next patient, which is a ureteroscopy for lower ureteric 5 millimeter lower ureteric stone on the left side. Before the patient arrived to the theater, there is a call from the recovery unit stating that your TURP patient catheter is not draining, and it is nicely clotted and bright red, and patient also showing evidence of tachycardia and sweating.
So I will immediately go and see the patient in the recovery room. When I get there, I will quickly assess him in systematic airway to exposure manner. I will check his observations, check his hemodynamic stability, and I will also have a quick look at the catheter. I will immediately, because I'm worried about severe bleeding, or probably is developing a severe infection, or probably this is a TUR syndrome. So I will keep an open mind and assess him very quickly. I will immediately ensure that the catheter is draining. If the catheter looks blocked, or if there is lots of bleeding, I will call for help so that my colleagues can join me. Somebody can start to take bloods, including group and save, while I will flush the catheter. And if the bleeding is still persistent, I can increase the fluid in the balloon and apply gentle traction on the catheter.
Okay. Unfortunately, even with this maneuver, it's not draining well. Sometimes a good amount of clot is passing through the catheter, and the catheter is not draining good.
Okay, so in such an instance, despite the bladder washout and the traction on the catheter, if I'm not able to control the bleeding, I will speak to the anesthetist and take the patient back into the and consent the patient to take him back to theater for endoscopic control of the bleeding.
Okay, so how are you going to consent him?
So I will inform him of the aim of the procedure, which is to clear his bladder of clots and to stop the bleeding. I will also inform him of possible risks, which are not massively different from the way I consented him for his prior TURP. The only other thing I will add is that if we are not able to stop the bleeding, it may require embolization or open packing of the prostatic cavity.
Before taking him to theater, what maneuvers you can do with the catheter to help with further drainage of the clots in the bladder?
So I can increase the fluid in the balloon to about 50 mils and apply gentle traction on the bladder neck for about half an hour. That helps to tamponade the bleeding and stop the bleeding in most instances.
Okay. So as usual, it's not working. So you're taking the patient to theater. So take me through the steps.
So so in a consented patient under anesthesia in the lithotomy position with the WHO checklist completed, I will take out this catheter and insert a resectoscope using the visual obturator. And once I'm in the bladder, I will aspirate out all the clots using a bladder syringe, after which I can also put in a cold loop to try and break any clots and aspirate it all out. And then once I've got good vision, good flow in the bladder, I would then put in my the rolling ball and try and gently cauterize any bleeding points in his prostatic urethra.
What is the best way to remove the clots from the bladder, large tendinous clots?
So usually I start by using a bladder syringe to aspirate, but once I've aspirated enough and there is still any clot I'm not able to get out, I can then use the Ehrlich evacuator to aspirate out clots. Usually I don't start with the Ehrlich because there is a risk of bladder perforation if the bladder is full of clots and at the first time. So I will first evacuate the clots with bladder syringe or a cold loop, and then when there is one or two more clots left, I can then use the Ehrlich to gently get it out.
Okay, so you have cleared some amount of clots in the bladder. Unfortunately, the clots are too much for you to tackle endoscopically. At 3 o'clock on the lateral wall of the prostate, you are able to notice a quite deep open perforation in the capsule. You are trying to get the hemostasis, but the blood keep on oozing from there. You are not winning endoscopically. What you can do?
So I've got the options in such an instance will be either embolization if available, but if there will be any delay in getting this, I will proceed to open packing of the prostatic urethra.
How will you do that?
So using a lower midline incision, I will dissect down to the bladder and open the bladder between two stay sutures, after which I will pass in a swab down into the prostatic urethra to apply tamponade. Sometimes if I'm struggling to get the swab down to the prostatic urethra, I can pass a catheter from the urethra and then attach the swab to the catheter, and then I will pull the catheter down and I will draw the swab into the prostatic urethra.
Okay, so what will you do next? That creates a kind of clarity, and the bladder is now clear. There is no fresh bleeding coming into the bladder neck from the prostate. Next steps?
So in that instance, I will close the bladder and close the wound gently, and then I will take him to the HDU, and then I will aim to bring him back to the theater in 24 to 48 hours, by which time the bleeding should have completely stopped to remove my pack.
Okay, so let us take the next scenario where, in spite of this packing and using the catheter to give traction, the pack gets soaked up and the bleeding persists. Any other steps?
So in such an instance, I could arrange embolization if that is available and will not cause any delay.
Okay, any other steps available when you are in the laparotomy position? You have opened the bladder, you can see the bleeder, but it's not coagulating with your available equipments, and the traction is not working. Any other things you can do?
I can also probably put in I can diathermize it through the abdomen using my diathermy, or I can run a suture through the area to tie up the vessel through the open operation.
Okay. You are taking the patient after 48 hours, you said. What is your plan in 48 hours? Patient bleeding is now settled.
So I didn't get it. As the bleeding settled.
Bleeding settled now. You are taking the patient back to HDU. You want to take the patient back to theater in 48 hours. Why is that?
So because I want to remove the pack. So
how are you going to remove that?
So I will, after the patient has been fully resuscitated in the HDU with input from colleagues in intensive care, and the patient is stabilized, I will bring the patient to the theater, or I will open the wound and then I will gently remove the pack, after which I will close the bladder in layers and perform a leak test, and then I will close the wound.
Okay, in this 48 hours, what are all the main other components you will look into other than the bleeding?
So I will also ensure that the patient is not septic, is not having TUR syndrome, and that the patient is clinically stabilized.
Okay. When you took the patient to the theater immediately after the TRP on the first instance, there was heavy bleeding noted, and as I said, the hemoglobin also dropped from say 13 to 7. How are you going to manage his hemoglobin drop?
So I will activate the massive transfusion protocol, because I'm worried with massive bleeding, so considering such an acute drop in his hemoglobin. The massive transfusion protocol involves I can get the flying squad blood in the theater, O negative blood, to start transfusing, while I will ring the lab, I will bleep the lab, and they will send 4 units of red blood cells, 4 units of FFP, and 2 units of platelets over. And we also have a dedicated porter who runs between the theater and the lab. And then once we no longer need blood, we need to let them know so that they can step down the transfusion request.
Good, well done. I'm happy with your massive blood transfusion protocol. Not necessarily every time it has to be O negative. If the patient already had cross matched and you know the blood group, and if the correct blood group is available, we can still go for the patient cross matched blood group first, and then the O negative may be taken up if the specific blood group is not available. If the patient is say B positive, and if it's not available, O negative is like a universal transfusion one. So starting from the first, I wish you to mention a little bit more about the bladder irrigation and trying to evacuate the clot in the recovery room. A little bit. I mean, you mentioned more about few other things. So you can try to do irrigation. Maybe you can even change from 3-way catheter to a 24 French silastic 2-way catheter, which can give you a better lumen for bladder irrigation using like a data syringe, as you said. And there are few other maneuvers like giving a traction in the recovery itself. Then you need to explain how are you going to give the traction. Say for example, the balloon can be inflated up to 50 or 60 ml, and we can attach half a liter or 1 liter normal saline to the catheter, and it can be hanged across the edge of the table, or the traction can be given with tapes with the patient's own thigh, medial side of the thigh. The other way is reducing the balloon to 15 ml, so that when you apply traction, there is a possibility the balloon can slip into the prostatic cavity, and then you can even inflate after that, depending upon your resection, into maybe another 10 or 20 ml, so that it fills the prostatic cavity. Putting a balloon into the prostatic cavity is very tricky. You don't know whether it's in the cavity or not, so there are a lot of disadvantages to that, but these are all the usual techniques explained. You can present it as, I will do the bladder neck traction, I am aware of the placing the balloon in the prostatic cavity for inflation, but in my practice we don't do that, something like that, so that if the examiner is a bit of an old timer, he will be happy that you are aware of the using balloon in the prostatic cavity. In fact, there was a time where we had dedicated 2 balloon catheters, where one balloon will be in the bladder, and one balloon will be in the prostatic cavity. But those days were gone now. So that is extra points which you can add in the initial bladder wash in the recovery room. I'm glad that you brought in embolism here and there. Obviously, the examiner will not take you to embolism because they want to discuss the emergency from the urology point of view. One thing which you can try is ligating the pedicle. You have opened up the abdomen, you have the prostate, you have the bladder, so you know the pedicle, and in the endoscopy, if it shows left sided 3 o'clock, a deep perforation in the capsule, try to ligate the pedicle on the left side. So that is something which you can consider. So you can decide whether you are ligating the inferior vesical pedicle and trying to ligate as much distal as possible, so that inferior vesical artery branch is given, and then you are ligating only the prostatic branch of the inferior vesical pedicle. Challenging. I've never done that in my life, thankfully, but they're all the procedures available. The other thing, other than placing a swab to get the hemostasis and bringing the patient back, you can try Surgicel. The concept is, if you keep Surgicel and give a traction, then you don't have to bring the patient next time. That is the concept. So Surgicel can stay there. I don't know whether the Surgicel will cause any long-term bladder neck contraction, or it can even cause outflow obstruction. I don't know, but theoretically Surgicel is supposed to get absorbed into the body, and it will spare you from bringing the patient next time. Ligating the pedicles, placing Surgicel instead of removable swabs, these are all given in the books. These are all box standard given in the books. How much practical, we don't know, but if you bring in as many tips and tricks under your sleeves, that gives the confidence that yes, you know everything under the sun. Okay. And as I said, massive transfusion protocol is very important. Your values of 4 packed cell and the values were correct, and just make sure you use the patient specific if available, other than O negative as a second step. Okay,
Thank you very much.
good. Can we start the next scenario?
Yeah, I'm ready. Thank you.
Okay, good. Your time starts now. You have a patient in the medical ward. The reason why he was referred you to is his PSA is found to be 2000, and he presented with a fall. On examination, he had weakness in the lower limb. And how are you going to evaluate?
So I'll consider this as an urgent emergency and will attend him in the ward. My concern here is whether there is a metastatic spinal cord compression. I'll see him. I know his PSA is raised. I'll make sure that he's pain-free, give him analgesics if he's in pain. We'll do a quick focused neurological examination, mainly to look for the sensations, motor innervation, dermatomes, and reflexes, and see if is there any signs of spinal cord compression. I'll also ask about whether he's has got any urinary symptoms, any bowel problems, and regarding his pain, whether it has increased compared to the previous values. And going further, I'll review his past medical history and any medications he is on, previous surgical history, whether he's known to have prostate cancer, whether he's already on any medications for prostate cancer. So this will be my initial approach. If my clinical examination and history point towards metastatic spinal cord compression, I will initiate the metastatic spinal cord pathway, which includes a MSCC coordinator, and then arrangement of a MRI scan. This will be a whole spine MRI scan to see for any compression. If there are any signs of spinal cord compression, I'll start him on dexamethasone 16 milligram stat, along with a proton pump inhibitor, omeprazole, making sure that he has no previous history of any peptic ulceration. And so that will be my initial approach to him.
So why dexamethasone? How it works?
Because there is a metastatic spinal cord deposit, it can compress on the spinal cord, and that can worsen the neurological injury as well as the pain. Dexamethasone acts by decreasing the spinal cord edema, and thus it can at least prevent the initial progression of spinal cord edema and neurological deficit.
Why omeprazole?
Omeprazole is to prevent the gastric symptoms and bleeding associated with high dose steroids.
Okay, I'm sharing the screen. Are you able to see the screen now?
Yeah, you can see that. Thanks.
Okay, so this is the MRI. Let's go from one end to other end.
This is a sagittal view of a MRI scan of the whole spine. The most striking abnormality is you can see a change of signal at the level of, I believe that is a lumbar artery. Lumbar vertebra. And yeah, okay, so that's the most striking abnormalities in the upper part, in the region of the thoracic vertebra, upper thoracic vertebra. So I'll be going through the whole spine to see if there are multiple metastatic deposits, which is not uncommon when there is an underlying malignancy.
So if you see the cross-sectional images, it's well seen in sagittal compared to cross-section, but in cross-section you can see some involvement of the spinal canal. There are some obstruction few places. Okay. So there is a good amount of metastasis obstructing or compressing the spinal cord. Okay, so the diagnosis, let us assume like L3, L4 level spinal cord compression extending into both the left and right side pedicles. Okay.
So this is a medical emergency now, the metastatic spinal cord compression because of prostate cancer. So this needs a multidisciplinary team approach. I'll tell the patient and his carers or family about the diagnosis and the need for further treatment. I will involve the cancer nurse specialist. We'll start him on dexamethasone, degarelix, which is the LHRH antagonist. So degarelix is given as 240 milligrams subcutaneous as initial dose, stat dose. I will make arrangements for him to be discussed in the MDT to take it forward. I will involve the orthopedics team initially and the neurosurgical team to see if we need, and the oncology team as well, to see if he needs any fixation of the abnormal lumbar spine, or if any external beam radiotherapy is needed if his pain is not controlled with dexamethasone and painkillers. I'll inform the nursing team that from that point onwards, until a decision for the spinal meds is done, he has to be log rolled, and then any movement should be done with care. And also, if he needs to go for toilet, we can use slip pan instead of taking him to toilet. So these are the measures I'll do initially. We'll discuss the MRI with the on-call radiologist as well to make sure that there is nothing abnormal other than this spinal cord compression seen. If he has got any difficulty in passing urine, which is not uncommon with metastatic spinal cord compression, and if there is any urine retention, I'll inform him about this thing as well, and then make arrangements for a catheter insertion. So this will be my initial approach to him.
Why we are log rolling him? Why we are not allowing him to ambulate?
Because until he is evaluated by the neurosurgical or orthopedic team, we have to make sure that during movement there is always a risk of further, because these spinal cord metastases are really brittle bone, and there is a risk of further collapse of the bones and can worsen the condition. So initially we have to make sure that until any surgical intervention is planned, the spine needs to be stable to prevent any further deterioration.
Why are you selecting degarelix?
That's because degarelix is a LHRH antagonist that can act really quick. So two main important things are: one, it can decrease the testosterone to a castration level within 24 hours. And two, it will not cause any testosterone flare, which is a bit of dangerous condition when there is a spinal cord compression. And also NICE has approved degarelix in these conditions where there is metastatic spinal cord compression with bladder and bowel symptoms or severe pain.
Okay, you tried your best. Unfortunately, your Macmillan team is not able to get the Digarelix. It's not available in the pharmacy, and it will take a bit longer time to arrange it. As far as the spinal orthopedic teams are concerned, they said there is no need for any intervention. He has enough amount of spinal canal support, and we can treat him conservatively. So, what are you going to do?
So two things I have to make sure is that I can start him on bicalutamide at full dose, 150 milligrams, continuous. And then I have to, because there is no plan for intervention, I have to plan for the gradual tapering of the steroid dose. So I can make it 8 milligram once daily and then gradually stop it, taper it over the next week. We have to continue the PPI along all these times and continue his analgesics. Once it is clear from the medical team that, the orthopedic or neurosurgical team that there's no more intervention needed, we can start mobilizing him. So I'll involve the physiotherapy team at this point of time. If he has got any catheter, I'll keep it until we have given him the Degarelix or until his PSA has come down to a acceptable level.
Is Digarelix is not available? What are the steps you have for that?
I can give him bicalutamide initially and then start him on LHRH agonist. One most commonly used one is goserelin, Zoladex, but we have to wait for the testosterone flare risk to come down, especially because he has got a spinal cord compression. In that case, I will wait for 2 weeks on bicalutamide and then start the LHRH agonist Zoladex at 2 weeks time. We'll continue the for 2 more weeks and then continue Soladex every 3 months from there.
Okay, I had one more question, which is the patient recovered from the neurological deficit, and how are you going to maintain his bone health?
Yeah. So in that case, according to the guidelines, we should ideally do a DEXA scan, see what his T score is. However, this is not widely practiced. I know that. What we do is to supplement him with vitamin D and calcium tablets and make sure that his calcium levels are normal in the following follow-up, along with the check of PSA to make sure that it is coming down, because the PSA response to LHRH agonist or antagonist can be taken as a prognostic factor.
Okay, good. The only thing I can add is, in case of the bone health, you can dwell a little bit on the bisphosphonates. There are various types and formulary available for bisphosphonates. You can take it even up to radium, which is good for the bone health. Injections, Zomita injections, on any bone related pain. You can even use radionuclides like strontium and samarium. So just have a kind of a separate list of things for bone metastasis management, starting from vitamin D, calcium replacement, moderate activity, maintaining the bone health, good amount of food intake, and bisphosphonates with injection Zomita infusion if needed, and radioactive things like strontium, samarium, going up to radium, which is higher in the order. Okay. It is slightly outside emergency, so I didn't concentrate it, but there may be a different metastatic scenario for the prostate cancer table, isn't it? I'm happy with your initial dose of dexamethasone, coordinating with the medical team, spinal surgical team, etc. I'm happy with you starting Digarelix. You can bring in the risk of pathological fracture quite early, because it's better to tell the patient well ahead rather than just saying don't mobilize more, we will do only log movement. You can tell the patient the risk of pathological fracture, because if it happens, then at least patient will be aware that okay, the doctor warned me regarding that. I'm glad you brought in nice guidelines about the usage of Degarelix in spinal cord compression or anything. It can be even for ureteric obstruction, extensive retroperitoneal lymph nodes. These are all some indications for Degarelix, those with high PSA. The one thing, a very big thing which you missed, is the role of bilateral simple emergency orchiectomy. If the Degarelix is not available, there is an option to take him patient to theater. You can do under local anesthesia bilateral subcapsular orchiectomy. What do you think about that?
Perfect. I mean, yeah, that should be the right thing to do rather than waiting for LHRH to act.
Yeah,
Sorry.
there is no role for LHRH antagonist in this situation because it's very very tricky. Even though you cover with bicalutamide, there is no assurance that he may improve after fourth day. Once you start LHRH, he may get into much more worse state. So given the choice to me, I will not bring in the LHRH injections in the full discussion, and I will take the patient to theater for look. He may not be fit for anything. He may not be fit for spinal. He's still in the log rolling protocol, so we can just log roll him to theater position, and bilateral local anesthesia, simple subcapsular orchiectomy is still holding. We are not doing it regularly. I think that's why you guys are not able to bring it in, isn't it?
Quite a long time since I did it, but yeah, that's important. I had to remember that. Thanks.
Yeah, good. Well done. Can we go for the last scenario?
Yes, please.
Okay, your time starts now. You have a patient in the gynecology ward. She had left-sided radical orchiectomy with adnexal mass removal for endometriosis and other reasons. And the reason for the referral is she developed a abdominal swelling on the left side, and the scan ultrasound done by the gynecologist showed a kind of fluid collection in and around the left kidney, pushing the left kidney. Her renal parameters were fine, and she is afebrile. She is having good amount of urine output. And so how are you going to manage her?
So I would want to see this patient promptly on the ward, and I would want to first ask about the surgical operation that was done, how difficult it was since it was for endometriosis, if there was any intraoperative complications. I want to also know if this patient has had prior abdominal surgery or even radiotherapy. I want to know the morbid lower urinary tract symptoms of this patient, and then I would ensure that this patient is fully stable by checking the observations of this patient, and then I will examine this patient in front of a chaperone, the examination of the abdomen to look for I may be able to palpate the mass that was picked on the ultrasound. My main concern is this patient has got ureteric injury with urinoma. So I would check the blood parameters to be sure everything is normal. And in this instance, since my concern is ureteric injury, I would then organize a cross-sectional imaging, which will be a CT urogram plus a CT cystogram, just to rule out any bladder pathology.
How come you have focused on ureteric injury? What other possibilities available for her?
So it's possible this patient has got reactive hemorrhage leading to hematoma collection, or a bladder injury also causing urinoma.
Okay, yeah, bladder injury also is possible. Okay, so what imaging you're going to arrange?
So I will do CT urogram plus CT cystogram, and then I'll take it from there. Yes, I want to review the CT urogram or cystogram. The other option is to take this patient back to the theater to do a taking consent from the patient to do a GA cystoscopy.
Okay, so you're doing
GA
CT scan.
cystoscopy and retrograde.
Good. So you're doing CT scan first, and this is the picture. Okay.
So this is CT scan of the abdomen and pelvis showing X-ray images coming from the top down. I can see the right kidney is encased in, the left kidney is encased in fluid collection and appears slightly enlarged. There's a large fluid collection from around the kidney down to the pelvis. There is a contrast extravasation into the collection. The right kidney appears normal. So there is a large, there is also compression of the pelvic calycia system with slight dilatation. I can't see the bladder section on this image. Okay, yes, I can see contrast in the bladder as well, which appears well outlined. There's also a tracking collection just above the bladder, I think, on the left side.
Okay, so this is the diagnosis. Okay.
Yeah. So with this picture, I'm worried this patient has got ureteric injury, which is just about the level of the mid-ureter, and then there is large urinoma associated with this.
Okay. So what are you going to do?
So I would want to drain the urinoma, and then I will try to take this patient to the theater to, drain the urinoma and then arrange a nephrostogram, nephrostomy plus or minus antegrade stent insertion. If this is not possible, I want to take this patient to the theater to do a cystoscopy to rule out any bladder injury and do bilateral retrograde ureteropylogram. So the main aim on the left side will be to try to pass a stent through the injury. So I'll try to go with a sensor wire through the injured section. If I'm successful, I'll put in a stent and then organize a drainage of the urinoma and then put a urethral catheter as well.
Okay, let us assume that the sensor wire is not passing the site of injury. It's getting coiled distally.
So I'll try to go from the top by speaking to interventional radiologists. So percutaneous drainage of the urinoma, nephrostomy from the top, plus or minus antegrade ureteric stenting. The main aim is to divert the urine, allow the injured section to heal, and then bring the patient back for ureteric reconstruction depending on repeat imaging picture.
Okay, you are draining the urinoma and you are successful in asking the radiologist to keep a nephrostomy, but the radiologists were not able to pass the guide wire from the top. It gets coiled in the level of the injury. What is the next step?
So the next step will be a challenging scenario. I'll have a discussion with this lady. The option will be to do an open exploration and then attempt ureteric reconstruction. And so with this level of injury, I would consent the patient for either ureteral anastomosis over a stent or the use of psoas or Barry flap in conjunction with ureteral implantation.
So when are you going to plan the surgery?
I would, as the urine diversion is not possible, I would want to answer the patient for immediate exploration. However, I'm aware because of the associated inflammation, it may be challenging, but that will be my option as the urinary diversion from top is not possible.
Urinary diversion from the top is possible. She had nephrostomy in place.
Oh, sorry, I missed that. So urinary diversion is possible. So nephrostomy in place, percutaneous drainage in place. I will prefer to allow about 3 months to allow this the injured segment, the inflammation around the area to subside, and then I'll monitor the patient after insertion of the tubes for sepsis, ensure that the patient remains stable. I'll discharge the patient home on the tubes and bring the patient back for elective ureteric reconstruction. That will be my plan.
Okay, so in 3 months' time, let us assume the urinoma is nicely settled and you are bringing for exploration. Patient is in your outpatient clinic to discuss the procedure. How are you going to explain her?
So I will explain to the patient that it will require having another assessment of the injured segment. So ideally, prior to procedure, I want to do a nephrostogram, since a nephrostomy is in situ, to know the upper limit of the injury. And then intraoperatively, I want to do a left retrograde retinopylogram to know the distal extent as well. I might combine that with intraoperative nephrostogram. And then I would explain to the patient that it will require midline incision, good access to the ureter, the ureteric injured segment. Depending on the finding, I may be able to bring the two edges of the ureter together and then repair overextend, or I may have to do ureteric implantation and add adjunct procedures like psoas or Boari flap. But if I'm going to do that, I'll ensure the patient has got good bladder capacity.
Okay, what do you mean by psoas itch?
So psoas itch means, this is on the left side, so it means anchoring the bladder to the psoas muscle on the left side by making sure there is no injury to genitofemoral nerve.
Okay, good. We'll stop there. Possibly we may have progressed a little bit faster so that we can discuss the principles behind psoas itch and Boari flap, but I hope you are quite confident and aware in that. So
Yes.
again, my main observations are, don't err on the side of ureteric injury directly in the starting itself, because it could be a bladder injury. We don't know. Only as we go, we know. Possibly I got the title of the presentation as post ureteric injury. So don't get deviated by that. Keep a bit of a big open mind in the initial setup, and then after the first question, narrow it down. Okay, don't get tunneled into ureteric only. It could be bladder injury, it could be even a kidney lower pole injury causing urinoma, it could be anything, even though the kidney lower pole injury is not possible after a complex left adnexal mass removal. Keep yourself a very broad approach. And you almost took the patient to under anesthesia, cystogram and retrograde without CT scan. So CT scans are wonderful, so you can get so much of information from CT scan. So try to do the non-invasive test first before going for any retrograde or cystogram. Or you may have said about cystogram in the outpatient in radiology suite. Even then, it's nice to have a CT scan discussed first. Definitely examiner will give you CT scan in these kind of scenarios. And the drainage of the urinoma is important. You can do few things like sending the drainage sample just to make sure that it's only urine. You can send the urine sample in the same time to compare the creatinine, the usual stuffs. But even though this scenario, it's straightforward urinoma, there is nothing other than urinoma. As you yourself know, we clearly said patient had urinoma drain, patient had nephrostomy placed successfully, but the radiologists were not able to pass the guide wire from the top. So antegrade stenting was not possible. So don't miss those things. As I said, there will be a paper and pencil. Please keep noting the important things what the examiner says, including values, patient's age, etc. Timing of surgery, once you know that patient is nephrostomized, you are quite comfortable in taking it in 3 months time. That's good. That will allow the inflammation, everything to settle down. It's a pain for the 3 months period. Make sure you're documenting everything quite in detail. There is nothing wrong in telling the examiner that this could end up as a medical legal challenging case. The patient may sue the hospital for the inadvertent ureteric injury. So I'll be very careful in documenting the details. There is nothing wrong in saying this. The examiners will really appreciate it, because that's what you should have in your mind in the real life practice. So what you are doing in the real life practice, you should show it in your exam. So bring the words of medical legal possibilities, and I will encourage myself and my team to make accurate documentation of the discussions, including in detail consent. And you can discuss about the estimation of bladder volume or the good capacity of the bladder volume quite early, because you know this patient may end up towards Boari flap possibly in the future. So you have brought the bladder volume in the end, but maybe you can bring it up a little bit early. And regarding reconstruction, if you are confident, you can say that I will do on my own, but there is nothing wrong in saying I will ask one of my colleague, a reconstructive specialist, to give me a hand. So the plan is everything, but most commonly these patients with the level of injury at mid-ureter will end up in a Bovary flap, which gives a better long-term solution compared to end-to-end ureterostomy if the injury is very, very small. Mid-ureters heal very poorly with end-to-end ureterostomy, and if there is a vascular damage, we don't know, it may not heal well. So it's always nice to have a Bovary flap which has much more success rate. Psoas hitch is only mainly for the lower ureteric and low mid-ureteric injuries. It only gives very small amount of length, and even if you do a Bovary flap, you can do a psoas hitch to make sure that the Bovary flap is without any tension. Okay.
Yeah.
And I thought of taking you to the discussions like you'll be keeping a JJ stent, and what are you going to do with the nephrostomy, or are you going to remove it straight away? My principle is, once the Bovary flap is done, once intraoperative stent is placed, we can keep the patient on a continuous draining bladder catheter, and we can clamp the nephrostomy. No need to remove it. It's better to have a clamped nephrostomy in case if something happens, if you need to do something from the top, or if you need to just unclamp the nephrostomy for any emergencies. Nothing wrong in clamping the nephrostomy. 24 to 48 hours, if patient behaves well, you can remove the nephrostomy. Patient will be sent home, and maybe a CT urogram in the presence of the stent in say 6 weeks time. Catheter can be removed in 2 to 3 weeks time. And once the CT urogram shows that the healing is nice, then we can remove the JJ stent. Patient may need further follow-up for at least 1 or 2 years, and don't forget to include that you will coordinate with the gynecology team to know about the histology of the left adnexal mass. It could be a cancer, so in the follow-up, she, even in 3 months when you're doing the Bovary flap, she is so depressed by the cancer diagnosis, and so you should be aware of what is happening in the histology. Okay.
Yes.
So this is
Thank
how.
you very much.
Yeah, this is how it should be a very comprehensive approach. You should behave as if a patient is sitting next to you and you are talking to it. I can say most of the things what I said you will be doing in your daily life, but how are you bringing it in the words to show the examiner that this is you? That's what more important in the exam. Okay.
Yes. Yes.
Good.
Thank you very much. That's very helpful.
Good. The easiest thing is, don't think it's an exam. Think it's like a daily life. What will you do in your daily life? First, a very strong knowledge, which you all have, and then behave as if you're seeing this patient in your daily life. And if you keep that in mind, things will come very automatically by protocol. Okay, if there are no other questions, can we conclude today's session?
I have got no other question.
Yep.
Sure, Mr. Dash. Thank you.
Good. Okay.
Thank you very much.
Good. Thank you for everyone for joining this emergency urology session. We are going to have at least 2 more vivas, one in infertility with a touch on the various andrology scenarios, and one on the penile cancer in next 24 hours. Wishing you a good week ahead.